Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today, still on our topic on mediastinum, we are going to be discussing prevascular compartment mediastinal masses. The differential diagnosis for a prevascular mediastinal mass includes thymic epithelial neoplasm, such as a thymoma, if the patient is middle-aged or older, or has a history of myasthenia gravis. Less commonly would have thymic carcinoma. Then other differentials include germ cell tumor, including teratoma if the patient is a young adult. Lymphoma is also another differential. Thyroid goiters are also a differential for anterior mediastinal masses when they descend into the retrosternal space. Now let's start off with thymoma. A thymoma is the most common primary tumor of the anterior mediastinum, and typically it occurs in middle-aged or older individuals between 35 and 60 years. Thymomas are associated with myasthenia gravis, where we have approximately 33% of patients with thymoma having myasthenia gravis, and approximately 10% of patients with myasthenia gravis having a thymoma. In addition to myasthenia gravis, thymomas are also associated with other diseases including red cell aplasia, hypogammaglobulinemia, and other paraneoplastic syndromes. Thymomas can pathologically be classified as either low risk or high risk based on histology, and they can also be classified as non-invasive or invasive based on whether the capsule is intact. About 30% of thymomas are invasive, and if it's invasive, the tumor may end up invading adjacent structures, including the airways, the chest wall, the great vessels, the phrenic nerves. When the phrenic nerves are invaded, you end up having elevation of the hemidiaphragm. That's a suggestive sign that the phrenic nerve is invaded. Thymomas are generally lobulated masses in the anterior mediastinum, and they are often off-center. They may calcify or develop necrosis, and drop metastasis from invasive thymoma spreads along the pleural and the pericardial surfaces. Hematogenous metastasis are uncommon. Rather, drop metastasis is what you end up getting in thymomas. That's the invasive type of the thymomas. Now in these images, we are seeing a case of invasive thymoma with drop metastasis, and this contrast-enhanced CT shows a slightly heterogeneous mass with calcifications here anterior to the aorta and the superior vena cava. And we also have two pleural metastases. We have one seen here. We have another one seen here. We mentioned that drop metastases run along the pleura and the pericardium. So there you have it. Next, we'll talk about some less common thymic lesions. We'll start off with a thymic carcinoma. Now, unlike a thymoma, thymic carcinoma is histologically malignant, very aggressive, and it often metastasizes hematogenously, unlike the drop metastasis that we see in invasive thymomas. And in thymic carcinomas, it metastasizes hematogenously to lungs, liver, brain, and bone. The prognosis is very poor. Distinction between invasive thymoma and thymic carcinoma is difficult by imaging alone. So in this image, it shows an anterior mediastinal heterogeneously enhanced soft tissue mass with some necrotic areas, and this is associated with a left-sided malignant pleural nodular thickening here, nearly encasing the left hemithorax and also involving the pericardium, which is inseparable from the mass. There's also some left-sided pleural effusion. This was a case of a thymic carcinoma. Next, we'll talk about a thymic cyst, another less common thymic lesion. And the thymic cysts may be secondary to radiation therapy. Example, those that are administered to treat Hodgkin's disease, and it's associated with AIDS or Sjogren's syndrome, especially when multilocular. Or it may also be congenital when it arises from remnants of the thymopharyngeal duct. A congenital thymic cyst may occur anywhere along the course of thymic descent from the neck, but most commonly in the prevascular mediastinum. CT scans will show a simple fluid attenuation cyst in the prevascular mediastinum, typically centrally located. It may measure greater than simple fluid in attenuation if it contains proteinaceous or hemorrhagic contents. The cystic nature can then be confirmed with an MRI. So in this image, we see a well-defined hypodense non-enhancing mass. The Hounsfield unit measured 24, which is a little high for a simple fluid. So this is likely to be containing some proteinaceous content. So this was a thymic cyst. Next, we'll talk about a thymolipoma. This is a benign fat-containing lesion with interspersed soft tissue. It may become quite large and will end up draping over the mediastinum. In this image, we see this axial contrast enhanced CT scan of the chest, and we see this huge heterogeneous anterior superior mediastinal mass, mainly of fat attenuation. We can also see thick soft tissue strands within without calcification or fat fluid level. This is actually a thymolipoma that has grown so large that it's draping over the mediastinum and even taking over the entire left hemithorax. Then we'll talk about thymic hyperplasia, which appears as diffuse symmetric gland enlargement without a focal mass. True thymic hyperplasia is a reaction to some systemic stresses like radiation therapy or burns, chemotherapy, even steroids. Such lymphoid hyperplasia is also associated with myasthenia gravis, systemic lupus erythematosus, rheumatoid arthritis, scleroderma, and Graves' disease. So in conditions like this, the thymus just reacts and gets hyperplastic. So there's no focal mass per se. It's just the thymus that has grown so big. So in this image, it shows thymic hyperplasia with 6 months interval. So this first CT scan is 6 months prior to the second CT scan, and we can see clearly the difference in size of the thymus between these two images. You can see the smooth margins and homogeneous enhancement of the thymus. Now we'll talk about some germ cell tumors. A teratoma is the most common mediastinal germ cell tumor, usually encapsulated and often predominantly cystic in nature, but fats and calcifications are also very common. A fat fluid level, if seen, is specific for teratoma, but it's not commonly seen. Teratomas can rarely be malignant, especially if there is a large soft tissue component. Then you can be thinking probably some malignancy in there. Apart from a teratoma being the most common mediastinal germ cell tumor, a seminoma is the most common malignant prevascular mediastinal germ cell tumor, and it occurs almost exclusively in men between the ages of 10 and 39 years old. Pleural effusions are rare, but pulmonary mets are relatively common. This image shows us a well-circumscribed anterior mediastinal mass, and this mass is heterogeneous with macroscopic fat in some of the areas. We can see soft tissue density in some of the areas, and we can also see coarse calcification in some of the areas. This was a teratoma, a benign germ cell tumor. Then we have malignant germ cell tumor, and this occurs almost exclusively in males, just like we mentioned in the seminomas. There is a higher incidence of mediastinal germ cell tumor in Klinefelter syndrome, and this image shows us a large heterogeneous mass in the visceral compartment with low density components. There's also a calcific focus, and gynecomastia is also seen bilaterally. Histopathology showed mixed components of teratoma, high-grade sarcoma, and leiomyosarcomatous differentiation. So this was a malignant germ cell tumor. Now to lymphoma. Both Hodgkin disease and non-Hodgkin lymphoma are important differential considerations for anterior mediastinal masses. A lymphoma often presents as an aggressive, invasive mass. There's usually associated mediastinal lymphadenopathy, which can be in the prevascular or the visceral compartments. In particular, internal mammary lymphadenopathy is very highly associated with mediastinal lymphomas. Calcification is rare in the untreated lymphomas, but after treatment, calcifications are very common. This image shows us a large soft tissue attenuation mass occupying the anterior mediastinal region, displaying homogeneous attenuation with low density areas of cystic changes inside. It extends to the middle mediastinum and it occupies the pretracheal space and also involves the right hilum as well. We can see there's compression of the superior vena cava and the aorta and great vessels appear encased. We also see mild right costal pleural thickening and enhancement, which suggests infiltration with mild pleural effusion also seen here. Important to note that lymphomas are quite soft and they like to mold around structures. That's why the description of encasement around the vessels is important. That brings us to the end of this discussion. The next topic would be visceral compartment mediastinal masses. As usual, I hope you are finding value from these discussions, and if you are, share to someone you think might also like it. Give it a like, comment, and subscribe if you have not subscribed yet. I will see you in the next one.